Wonderful. Welcome. Thank you so much. Welcome everybody today to the MCC seminar series. It's wonderful to have you all here. I know it's a busy week with spring break, so it's great to have you all along. It is my absolute delight to be introducing our speaker today, Dr. Abraham Aragones. He is an MD and a public health researcher with just the most spectacular career. And if you take a moment to read about some of the things that he's done, I'd encourage you to do so. He is based at Memorial Sloan Kettering Cancer Centre and has done work in so many areas, whether it's people facing end-of-life care through to the health of immigrant taxi drivers in New York City to COVID, but the bulk of his work has been around cancer screening and increasing cancer screening with a particular interest in HPV and in working with providers as a point of influence to see how we can improve access to HPV vaccination. And that's been particularly for Latino communities. But again, I'd just say sort of an impressive collection of work. So I'm very delighted for our talk today to hear more about the work that he has been doing and the impact of access to care on HPV-associated cancer disparities, lessons from 4 large and diverse cities. And I hear this will be the first time some of these results have been shared in a seminar, so I'm very excited. And with that, I'll pass on to our speaker today, Dr. Aragones.
Thank you so much, Rebecca, and thank you so much for the invitation. This is it's really a pleasure. I'm going to apologize for my voice. This is the consequence of having a young child in daycare and constant illness. So I hope I can do my best. And what I was discussing with Rebecca is I'll have a presentation of 40-45 minutes or so. I'll try to be quick, to the point, and then we'll leave as much time as we can for questions at the end. And once again, thank you so much for the invitation. It's really a pleasure to present my work, to have the opportunity to present my work. So I want to give you a little bit of background on what I do, how I got to the study that I'm actually, the data that I'm going to be presenting at the core of what I'm presenting today. So the title actually addresses or discusses the data that comes from a large R01 study that it started about 5 years ago. It's almost ending. And it is looking at HPV vaccine access and uptake in 4 very different large cities around the country. And that includes New York City, Chicago, Las Vegas, and El Paso in Texas. And I'm going to tell you a lot more about that, and the slides associated to the title will be at the end. I want to tell you a little bit of maybe 10 minutes or so of a story of how I got to this study and why we actually implemented it. But before that, and I know some of you already know very well this is just a little bit of background. Let me give you some of the information about HPV and HPV-associated cancer. As I said, most of you know that HPV is perhaps the most common sexual drug infection. The main reason why it's so common is because of the way that it's transmitted from person to person. It is actually enough to have skin-to-skin contact, anal, genital, and mouth contact with a similar part of the body. And that's enough to actually transmit the virus from one person to the other. It is speculated that around 80% of adults actually either currently have or have had HPV at one point in their life. So if you look up or down in your Zoom and who's attending, probably all of us either have or have had HPV. The problem is that around 10% of us, 10% actually that get the HPV, and this is men and women, turn into what it's called a persistent infection. So those 10% that have the HPV in their bodies for long term are the ones that are at high risk of developing the associated cancers. We divide HPV into high risk and low risk. The HPV low risk are associated with warts, genital warts, mouth warts, but most importantly, high risk types are associated with 6 different types of cancer. Of course, this is among women and men, and that includes cervical cancer, anal cancer, oropharyngeal cancer, penile cancer, vaginal cancer, and breast cancer. So the burden of HPV-associated cancer is disproportionately distributed between populations. So here we see disparities everywhere. So anyone that is interested in HPV or cancer disparities can find something. Cancer disparities and race and ethnicity can definitely find, or gender can definitely find a disparity in this area. And of course, all these disparities are could be overcome by some of the methods that we have to prevent HPV. So a few of the most important ones that I feel are important, because again, it takes the whole continuum of disparities, the whole continuum of populations when it comes to HPV and cancer disparities. There's slightly more women diagnosed with HPV-associated cancer than men. This might actually sound like nothing new, but the large majority of the population and the audience, the lay audience, thinks that HPV and cancer are only occurring in women. But the truth is that only slightly more cases of HPV-associated cancer occurring in women than in men, just slightly. And that is actually forecast to change within the next 5 to 10 years, no more than that. Men, particularly white men, have the highest rates of oropharyngeal cancer associated to HPV or back of the throat cancer. These rates actually have increased tremendously in the past 10 years and are suffering from this type of cancer tremendously. And again, in particular, white men. Oropharyngeal cancer survival, though, in the other side, is significantly higher among white men, despite the fact that they're actually diagnosed at a much higher rate. All other races and ethnicities are actually have lower survival than white men. Black women have the highest rates of overall HPV-associated cancer. So all of them, if you group them from the 6 sites, from the 5 sites in the case of women. And Latinas have the highest rates of cervical cancer. Black women are at the highest risk of dying from cervical cancer. Anal cancer survival is significantly higher among women compared to men. And if you're older, you have a higher rate of HPV-linked vaginal, vulval, and penile cancer, as well as anal cancer. So again, you can find disparities related to race, ethnicity, age, across the spectrum of cancer associated with HPV. These are some of the numbers that we find currently of cancers associated with HPV in the United States. This is actually a very conservative slide. We think it's anywhere between 45 to 60,000 a year. And if you look in the middle, the percentage probability caused by HPV type, that is also very conservative. For example, we know there are about 12 to 14,000 new cases of cervical cancer a year in the United States. And according to different studies, we find that over 99% of those cases are actually caused by or linked to HPV. In this case, we have 91% in the middle. It's fairly conservative. At the end of the day, what you can find here, what I think is very interesting, is that one, the enormous number of oropharyngeal or back of the throat cancer, of course, almost 4 times or 5 times higher in the males than females, and high numbers of high percentage of association with HPV. So these are all the numbers that we have. Potentially, we can prevent over 35,000 cases, where you can see on the bottom right, the total 33,737, again, conservative number, but we believe that with the HPV vaccine, about 35 to 40,000 of these cases can be prevented. We have a vaccine. As I was saying before, the disparities that we observe should not occur. And as probably you have heard, cervical cancer, for example, many of these types of cancer can be fully eradicated in our lifetimes if we actually administer the vaccine at the optimal levels, which we're not doing. And we'll discuss that in a few seconds. HPV vaccine, the current one is the HPV-9 or 9-valent. It's highly effective, highly safe. We have an enormous amount of data actually looking at effectiveness and safety. It's given in 2 or 3 doses depending on age. If you're 14 or younger, you receive 2 doses. If you're 50 or older, you receive 3 doses, which is important because you need to complete this series in order to be to receive the full effectiveness of fully protected against the 9 types of HPV. So it's recommended at age 11 and 12, and we'll discuss that in the next few slides. But it's recommended at 11 and 12 for boys and girls, although you can start at age 9, and it's available all the way to ages 45. The effectiveness reduces as the older you get. The idea is that you administer the vaccine before the person becomes sexually active and it is in contact with or infected with any of these HPV types. HPV vaccination rates remain well below optimal levels. The optimal level is around 80%. And the sad part, and you can see these numbers here, first dose or uptake of the first dose is anywhere between 55 and 60%, full series 40 to 50%. You can actually find different numbers depending on what population you're including, what eligible population you're including. The fact is that in almost everywhere, almost any database that you search or that you look for, you will find that numbers are well below the 80% optimal level. And what is more important is that in 2021, and this is mostly due to COVID, but in 2021, there were more than 2 million less vaccines administered, HPV vaccines administered to the eligible population than in previous years. So despite the fact that it was slightly increasing in the past decade, the utilization of this vaccine, although very, very slow increase, apparently last year has been a big hit for those of us working in this area, for those of us interested in getting more and more eligible children and adults vaccinated against HPV. One of the key things here is that HPV is not mandatory for school in most states. There are a few states that actually are, for example, in Rhode Island, so it's part of the immunization schedule and immunization requirements for school. HPV is one of them. And as a natural experiment, of course, Rhode Island has one of the highest HPV vaccination rates in the country. That is not the case in the large majority of states, and that includes my state, New York State, as well as any of the states that are included in the work that I do. So here, there's actually a body of evidence and literature that can take forever to cite. I just want to summarize some of the HPV vaccine barriers, recommendations, hesitancy, perhaps reasons for hesitancy at all levels. And this is just to give you a little bit of background on why we address some of these issues in some of the studies that I'm going to be presenting in the next few slides. So we know that lack of recommendation or lack of a strong recommendation from the provider is the most important barrier for obtaining the HPV vaccine. There actually, here in this specific barrier, we include lack of time. Lack of time is included in this specific barrier because we know that one of the things that providers are not doing, and I'm talking about all providers, either nurses, physician assistants, or physicians who provide the vaccine, who administer the vaccine in their settings, actually have multiple misconceptions about the vaccine and their populations that they're caring. And to give you an example about this is that we have an interesting study that I'm not bringing here. I don't have the data here, but we have an interesting study looking at some of the perceived barriers from the provider side about their patient population for the HPV vaccine. And most providers, about 80% of providers, thought that if they raise the issue of HPV vaccine with their patient population, that was going to create a long conversation, was going to be a waste of time, and was not going to allow them to actually do many of the other things that they needed to do during the wellness visit or that acute care visit. So that is important. There are misconceptions here. There are other reasons why lack of time includes other reasons as well too. It could take a while to actually administer the vaccine. We ask the patient to remain in the within the setting, the clinical setting, for 10 minutes or so to avoid a fainting, which is a common side effect for a common consequence of an injection for all adolescents actually, and for all vaccines, not just HPV. So we ask them to stay for 10 minutes. Sometimes the providers don't have space to do that, etc. We know that actually clinical settings are, and the resources that those clinical settings have are very important to increase or reduce HPV vaccination rates. For example, we know that if the clinical setting has an immunization champion or a nurse that is actually in charge of immunizations and education, administering the vaccine, etc., we know that the rates actually increase in that population, in that setting. Lack of reminders reduces the within the clinical setting in their EMRs, etc., reduces the HPV vaccination rates. That's from the provider side or the clinical settings. From the parental side or the adolescents receiving the vaccine, we know that lack of awareness is key. And most of my work has been in the Latino population, but I do actually have several studies, including many other populations, including the general US-born population. And we know that this is true for all populations. So lack of awareness, lack of understanding of the HPV vaccine is key. Not knowing that there is a vaccine for this type of cancer, not knowing that HPV is highly associated with cancer, not knowing that HPV and cancer can occur as well in boys is very key as well too. So lack of awareness in general, not just of the vaccine, but also lack of awareness of the consequences of the infection of HPV with HPV. Reluctancy is actually key, and it's not so strong in the Latino population. It's not that they don't want the vaccine as an anti-vaccine statement, but rather because it's not mandatory for schools. So many of our populations actually go to their pediatrician, the children population, go to their pediatrician to get the immunizations needed for that year. And to be able to enroll in school, et cetera, and other programs. And when they're offered a vaccine that is not mandatory for that purpose, then they most of the time either refuse or postpone it. And we know that when the vaccine is postponed, most of the time they're actually not obtained. Misinformation is increasing in the general population, of course, but it's also increasing dramatically in the Latino population. So we know that social media and social networks and the misinformation that we obtain, they're not just about HPV vaccine, but in general, vaccines is actually becoming a bigger problem. A study funded by the NCI right now in our catchment area looking at this particular issue. And although I don't have the latest numbers, I had to come up with a report for the NCI less than 4 or 5 months ago. And we saw that in our catchment area, out of 200 parents that we recruited that have not vaccinated their kids, about 90% of them were exposed to misinformation in social media about HPV and other vaccines as well too, but specifically HPV. So we'll continue that work, and we're sure that this is going to be an area of focus for the future. And finally, in some of the aspects of the HPV vaccine barriers and reasons for hesitancy, that the main work of this presentation will show or tries to address is the issues related to policies that promote or discourage utilization. So we'll talk a little bit about health insurance. We talk a little bit about a safety net, a healthcare safety net, and other programs as well to navigate the system and obtain the vaccine. A number of providers in the Vaccines for Children program, which is the way that the large majority of vaccines are actually administered in this country, the program, which through the vaccines are offered. So how do we get to the study that I'm actually going to be presenting the new data that I'm going to be presenting you at the end? So let me take you through this series of studies that I started to implement about 10 years ago or so, or a little bit more. Most of them funded by the NIH, but also with institutional funding, and just show you a little bit of the results that sparked the interest to take the next step and to actually build upon them and come up with an interesting study that I think it's an interesting study at the end of this road. So here, about 10 years ago or so, we wanted to know how physicians, what were the perceptions of physicians serving large minority populations at high risk for HPV-associated cancer. How did they perceive the HPV vaccine? And one thing to note here is that we interview providers at all levels. So in hospitals, in small clinics, private practice as well too. A lot of the HPV vaccine is provided in private practice offices in the New York area, as well as in the other 4 states of this, the main study that I'm going to show you. So we make sure to actually target those private practice offices as well too. And we learned that only 32% of primary care providers were recommending the HPV vaccine routinely. And again, as I mentioned before in the previous slide, most of them cited lack of time as the most common vaccine barrier. And again, lack of time is the avoidance of even starting a conversation that could take a long time, and that could be also misperception. I mean, we know that in some of the cases, for some populations, a strong offering is enough to accept the vaccine and not actually trigger a long conversation. So again, not a lot of providers were offering routinely the vaccine. On the other hand, we wanted to know what the population thought, and we went to the population. We did some qualitative work. We did several focus groups, and we interviewed Latino parents of eligible children. And we found here, and we actually named this paper. It's available now. We named this paper, if they offered, we will get it, because most parents, one, were not aware of the vaccine, and two, were upset with their providers because they didn't get a recommendation for the vaccine once they were explained what the vaccine did and how it prevented cancer in the future, etc. So we knew that there was a gap there between providers thinking that that it was going to be a waste of time or take a long time to recommend the vaccine, and parents actually wanted that recommendation and be primed for that once they receive a little bit of education. Finally, parents also mentioned they wanted a reminder to know when the vaccines are actually should be given to their kids, and not just for the vaccine initiation, but also for the completion of the series. So from here, we jump into some interventional work. This is a non-randomized study that we conducted at the community level. The work that I have shown so far, it's considered community-based research. We're not doing it in any large clinical settings. We're actually expanding to the population through collaborations with multiple community-based organizations, et cetera. And this specific program was implemented in a community-based healthcare program. That the goal of the program was to actually, the community-based program was to connect the population, Latino population at large, to healthcare services. And as part of that, we implemented this program. The idea was to assess if an education intervention versus education plus a messaging reminder, so using a simple text messaging, was actually effective or shows some efficacy at increasing a vaccination rates. And we found a dramatic result, again, a non-randomized study, but we found a dramatic result that education plus text message at the community level, not at the provider level, but not in a clinical setting, but in the community setting, found that 92% reported vaccine uptake in the education and text message for the first dose, and 72% reported vaccine series completion, and that compared to 88 and 18% in the education only group. Again, this has actually been published as well too. So another study that we were interested in implementing, and we have implemented successfully, and we're actually about to publish the main results of this study, is a social marketing and technology to increase vaccination rates among Mexican American children. So this builds on all the previous work that I've been showing you, and adds actually this component of social marketing campaign. And we, at the community level, we targeted in community-based programs, we targeted the population with a social marketing campaign to increase knowledge, to reduce barriers for the HPV vaccine, and to prime parents to get the vaccine for their children, for the eligible children. So one of the things that we were trying to do, one of the areas that we have done with HPV is increase demand for the vaccine at the community level. You will find a significant amount of work done in the literature in increasing recommendation and at the clinical setting within the provider. And we've done some of that work as well too, and I'll show you some of that as well, I believe. But at the core of this is to increase population demand for the vaccine and to prime them. So once they get to the office, to their either children's wellness visit, etc., they actually either ask for the vaccine or they accept the recommendation from the provider. So that was the idea. Of course, we wanted to follow up with the text messaging as well too. We knew that worked, so we wanted to implement it here as well too. Over 90% of the population that we care for, and that was part of those community-based programs, reported actually using a phone, but also using a phone for text messaging services and using it often. So that was a high level of usage of text messaging. In this case, the outcome was actually an uptake in completion of vaccine series, and we recruited 182 participants and exposed them to videos, to pamphlets, to audio, and a short tailored educational session. One thing here that I want to mention is that we actually developed all these materials, these posters. This is a little bit older now, so you might find that there's some information like 3 doses that might not be correct, but we developed all these materials with the population. All the images that you see here actually came from the population. The information that is given here was actually a screened by the population, proposed by the population in some way, the population study. So here you can see that it discusses a significant amount of the importance of giving their children a good future, a better future, same way that most of these parents migrated to the United States, to Mexican immigrant parents migrated to the United States to improve the chances that their children will have a better financial future and more opportunities, etc. Given this vaccine, the HPV vaccine, is actually a way to provide them a better health future and prevent cancer. So we use that analysis, we use that messaging and implement it all in this different materials that we use in the social marketing campaign. So here you can see that 70% of adolescents reported receiving the first dose of the HPV vaccine, no significant difference between the groups. So apparently those that were exposed to the social marketing, regardless if they were actually follow up with a text message or not, there was a good percentage, a solid percentage of 70% that actually went and got their first dose of the HPV vaccine. When it came to the second dose, or in some cases the third dose, here there was some difference, and we know that reminders actually work here. 66% versus 48% completion of the vaccination series. This was significant. Engagement materials, so the amount of time that the participants were actually reading the materials, we actually account for that. The use of a navigator, because we provided also navigation for all participants if they needed to navigate the system to get the vaccine, and education and being present for the educational material, for the education session, were all significantly associated with vaccination. Text messaging, as I said before, was significantly associated with the series completion. So once we actually finalized this, Jake, we wanted to, we have approximately 91% of children in all our study cohorts. And this is actually, apologize for that actually, but I wanted to summarize something that I have not actually shown you in all these slides. One of the things that we noticed in all our work, and not only from HPV work, but also from other large studies with within our communities here in the area, in the New York City area, is that we have come to learn that about 91% of children in our study cohorts reported having a regular source of care. So access to care, at least in the aspect of having a regular source of care, is very high for the Latino children in our area. We also have come to learn that approximately 80% of children in our study cohorts reported having a regular source of, the 91% should be health insurance. I apologize at the top. The 80% is regular source of care. So we know that our populations are actually covered by health insurance and also having a regular source of care. And over 75% reported attending a wellness visit or immunization visit during the previous 12 months. So one key aspect here is that if the eligible child for vaccines were for HPV vaccine was more than 12 years of age, they reported 94% reported actually attending a wellness visit or immunization visit during the previous 12 months. The older the children get, the less wellness immunization visits occur, so less chances to provide the vaccine. Why I'm bringing this here is because we actually come to learn that this was also the case in other cities around the country. So a large percentage of the Latino population is actually covered by health insurance. Latino children population is covered by health insurance and also have regular source of care. But despite that, they're not actually getting the HPV vaccine. So we wanted to incorporate some of this to our next steps as well too. And this is actually the study that I wanted to bring you some of the new data. This is a study called titled EdTech HPV, a community approach using education and technology to increase HPV vaccination. This is basically the culmination of all the other work that I've been presenting. And one of the things I wanted to do is to expand our work to other parts of the country. Continue to target Latino parents, particularly mostly Mexican Latino parents, but in cities where those populations were very, very different. For example, the Mexican population in New York City, Latino Mexican population in New York City, it comes mostly from a specific place in Puebla, Guerrero, et cetera, it's the region, as opposed to Chicago, which is actually comes from a completely different place, mostly from the capital. But also in New York City, it's a fairly new population. So they've been here on average 7 years or so. But in Chicago, they've been there for generations. So it's has much more tradition. Needless to say, in El Paso, it's a border town. There's a lot of crossing. There's a lot of change in the population. And Las Vegas is a very new population for Latinos with very few resources. So we wanted to include a very diverse, very different cities to be able to evaluate environmental variables and other variables as well too, while we implement a randomized trial with two arms, an education and navigation arm and an education, navigation, and text messaging arm. And you can see that this follows some of the work that I presented in the past and builds actually and expands the work that we've been doing in the past. So it's currently in year 5. This is supported by the National Institute of Minority Health and Health Disparities. We currently have over 700 participants, and we're finalizing follow-up. It's been a complicated project. It's for those of you who have been doing this kind of work at the community level and having to do follow-ups. Actually, the follow-up includes actually a looking for a visit to their provider. These times have been very difficult. Many of our children in the study have skipped 2020 and 2021 and didn't actually go to their providers for general wellness checks. Or did not want to schedule a new appointment for the HPV vaccine. So it's been delayed a little bit, but it's finally catching up again. I am actually bringing you some information, some data, without including a full completion of the vaccine here, because since that's actually the main outcome. The population in the study, 721 participants, around 30% live in El Paso, Texas, 29% in Chicago, 23% in New York, and 18% Las Vegas. We have had actually a significant barriers to recruit participants in Las Vegas. Again, all this is implemented at community health programs that serve to, again, connect the Latino population to the healthcare system to help them navigate and access the care that they need. We look for parents of eligible children in those programs as they were waiting to receive other services, and we recruit them to the study. They were randomized to either text messaging or not at the individual level, and we follow them using a web-based text messaging service. All parents in the study were born in Mexico, so all of them are immigrants, and most 89 report having lived in the United States for more than 5 years, and you'll see why that's important. The average age of the parents in the study was 40 years, so fairly young population, and all self-reported as the child's main caregiver. We wanted to actually get the parents that actually took their kids to the doctor or that were in charge of making decisions about their health in the study, so we can better assess what actually played a role or was associated with an increase or decrease in HPV vaccination rates. So here's the tales from 4 cities, and what I think is interesting, and I'll show at the end some conclusions that we have come up so far. Again, this is unpublished data, and I'll be more than happy to discuss it further with you. I'm more than happy to receive criticism or reviews as a review panel. But this is so far what we have and what we think is interesting. So first of all, these are, again, a large immigrant population in 4 different cities, and only 25% of those parents that were part of this study of eligible HPV vaccine eligible children were insured. And this is actually not surprising. We have seen these numbers around the country. It's very low, but again, not surprising. New York City had the highest rate of parent uninsured. That's actually insured. That's actually 35%. El Paso, followed by El Paso 29, 22% in Chicago, and Las Vegas 9%. Important to say here that 76% had a public health insurance plan, Medicaid or state plan. There were some complications here because, for example, parents in El Paso in Mexico reported having a health insurance from Mexico, a public health insurance plan from Mexico, and that they were actually brought their kids, they crossed the border to provide care, either immunizations as well to the kids in Ciudad Juarez, which is across the border. We did include that as by insured parents, since they were able to receive no cost or low cost care for the children. 57% of parents reported having a regular source of care. 76% of New York City, 71% in Chicago, 51% in El Paso, and 16% in Las Vegas. This is fairly high and not surprising. Again, as I said before, these are very different cities, very different populations. The tradition of having Latino immigrants and even Mexican immigrants in those cities is very different, varies tremendously. Las Vegas is not has not been traditionally a place that has a large safety net for healthcare safety net for immigrants, much less for Latinos, much less for immigrants. So having a regular source of care, accessing those services could be actually a challenge there. And El Paso as well, again, some of the policies that we'll discuss in the next few slides decrease that. And again, in New York City and Chicago, we find that had significant number of programs to help access care and access regular source of care. And that has helped increase these numbers. In terms of the children in the study, so children of those parents in the study, 78% of children were insured, so fairly high. 90% in New York City. This is actually similar to the number that I showed you before from previous studies. 89% in Chicago, 63% in El Paso, and 60% in Las Vegas. Again, this starts telling you a story that in New York City and Chicago, two places with a large safety net, traditional safety nets for Latinos and immigrant populations, are actually doing better when it comes to ensuring the populations and ensuring the children population, as well as the accessing regular source of care. Again, as previously shown, over 90% were covered by public health insurance. That actually includes almost all the time at the state children health insurance program. 85% of children have a regular source of care, so 96% in New York City, 95% in Chicago, 80% in El Paso, 61% in Las Vegas. What I want to stop here 1 second and just mention that although we discuss access to care for children in particular, we, and some of these numbers, for example, 60% Las Vegas, 62% of insurance coverage for children in El Paso are not high. They're not as low as 25% for the parents. And we do have actually a significant number of the population at least overcoming this particular aspect of the access care. So the health insurance and having a regular source of care. So what we're not doing is offering the vaccine and offering other preventive care once they're actually in the visit. We should be able to bring them into the clinical setting, especially because these barriers are at least not as significant as they are in adults. So here are some of the results that we found are interesting. Children of parents without health insurance were likely to be uninsured. Again, 3.8 odds ratio, and to lack a regular source to obtain immunizations, 8.1. So this is important because policies that actually we believe that policies that might reduce insurance rates, health insurance rates in parents might actually have an effect on insurance status of their children, as well as a regular source of care in the children. Uninsured children in the study were significantly less likely to visit a healthcare provider annually, and less likely to have visited a healthcare provider for immunization purposes in the previous 12 months. Again, this is, it's obvious as I'm reading it, but this is what the data showed us. This is what the evidence is showing us. So if we do increase insurance rates among the children population, particularly in those cities and states that have actually low rates of insurance in the children population, we should be able to increase wellness visits as well as immunizations, et cetera. At least that's the hypothesis. 77% of children in the study visited the healthcare provider for non-emergency visit during the previous 12 months. So we have the population in the clinical setting. We already have them there. We should be actually offering the vaccine and getting them actually vaccinated. 84% in New York City, 83% in Chicago, and again, lower in the other two cities, El Paso and Las Vegas. There was a significant difference here. 93% of children with health insurance reported visiting healthcare providers during the previous 12 months, 12% of those uninsured. So clearly, if you're uninsured, if your child is uninsured, the chances of you taking your child for a wellness visit or for immunizations visit to their pediatrician or their provider is actually much significantly lower. Specifically, annual visits in per city or per location, again, we see that 88% in New York City, 79% in Chicago, 64% in El Paso, and 59% in Las Vegas, and this was significant. Children of participants reside in states with health insurance available for children in mixed legal status households and with higher children health insurance Medicaid income eligibility threshold were almost 7 times more likely to have health insurance than those living in states without such higher income levels or mixed legal status. And here is actually another way of looking at, if you actually increase eligibility for health insurance, you will actually increase out the vaccination and increase access for children and increase vaccinations at the end, potentially vaccinations. US born are over more than 7 times as likely for foreign-born children to have health insurance. And again, here we see some of the barriers for immigrant children to access some of the health programs that we have, particularly in some of the cities, including the study. Parents who live in their current state of residence for over 5 years were almost 4 times as likely to have health insurance for their children than those who had lived in their states for less than 5 years. It seems that parents actually that are that have roots in the city that they live and that have lived for more than 5 years, that have more exposure to the healthcare system or have actually needed to access care before, are more likely to have health insurance for their children than those that actually are moving. And one of the reasons why we looked at this is because we know that Latino populations move significantly within between states, not just within the city or the state. So we thought that it was important because, again, states have different policies, different access barriers, etc. And we found here that if you live, the longer you live in that state, the more access you and your children have. So more importantly, when it comes to HPV outcomes, and again, I have only for the uptake, not for the completion of the vaccine series. Children in New York City, Chicago were significantly more likely to receive the first dose of the vaccine than those in El Paso and Chicago, and El Paso and Vegas. That's 82% versus 53%. That was significant. The higher the number of programs to help increase access to care for the population, the higher the uptake of first dose. And here I actually have not been able to bring you some of the detailed data, but one of the things that we did is we took about a year and a half, beginning of the study, and then updated that as the study went, looking at all programs that actually within that city, within the metropolitan area where we're implementing, in those 4 metropolitan areas that we're implementing the work, we look at all programs that in some way aim to increase access to the Latino population or minorities in general. And we came up with a list of programs, and we, again, a simple look at that data here without doing much more. This preliminary work, we have learned that the higher the number of those programs available, the higher the uptake of the first dose. Again, not surprising, the easier to access care, the more chances to get the HPV vaccine. The length of time living in the state of residency by parents at the time of enrollment was significantly associated with higher uptake of first dose. This probably is associated with an increase in insurance rates as well too for their children, etc. Finally, parental perceptions of social burden. For example, immigrant caused a lot of discussion about some of the public costs or public issues. Was associated with lower uptake of the first dose of HPV vaccine. The high social burden perception were in El Paso and Vegas, followed by New York City and Chicago. Parental English proficiency was also associated. The higher the proficiency, the higher the first dose uptake. And we found that in El Paso and Vegas, the English proficiency was significantly lower than in Chicago and New York City. And just as a summary, because I want to give you some time to answer questions, shoot me some questions and answer as many as I can. Increased access to quality healthcare among all children, including Latino children, is strongly associated with positive health outcomes and with reducing or eliminating health disparities. In this case, through the HPV vaccine uptake, children's access to care was highly associated with their respective parents' access to care. And again, there's not a significant amount of evidence showing this, and we think that this is actually one of the strongest cases for to support this premise and to improve perhaps access to care and insurance, particularly with at the parent level as well, to have a repercussion in the access to care for children. Policies to reduce parental access, as I said, to health insurance may have significant role in health outcomes among their children. Uninsured Latino children, as well as Latino children without a regular source of care, were less likely to visit a healthcare provider, reducing the chances for preventive care, such as immunizations. A large care safety net, as I described before, with multi-level programs that aim at reducing access to care appears to be associated with improved health outcomes. And again, we have a very large data set of this. It's a very simple, what I show you here was a very simple analysis that we did. We expect to do much further detailed analysis of this data set. HPV vaccine uptake seems highly associated with parental health insurance status, child health insurance status, and the local healthcare safety net. And that is actually one of the key aspects that I wanted to bring here, because if any of you is actually aware of the discussions on or the studies and the evidence on HPV vaccine, most of the work that we have and that we've seen is in trying to increase providers' recommendation for the HPV vaccine, and that's actually key, definitely key, and we continue to do so, provide a strong recommendation for HPV. But we should not overlook some of the access to care, and specifically access to health insurance and regular source of care, and how they play a role in some of these healthcare outcomes, in particular immunization outcomes, that perhaps if we continue to increase, and we actually do increase access to health insurance for the parents of those eligible children, we might actually see an increase in vaccination rates and perhaps other positive outcomes in children, in the child or the children population. So with that, let me stop here. I know that I've given you a lot of information and I've gone through all these slides very quickly, but I'll be more than happy to answer any questions and have a discussion with you.
Thank you so much for your presentation. That's absolutely fascinating, and a really good wake-up call for us all to be asking those social contextual factors and doing any of this work, and the importance of what's happening in the parental context, the policy context, and with health insurance. I suppose I had a question, taking you know, the right of having you here as my host. So I'm curious about what would your advice be for clinics who are kind of looking at this data, and you know, I imagine some might look at this and feel a little bit helpless or a little bit overwhelmed about the role of the insurance rates for parents. Are there takeaways that are good for integrating into clinical practice and addressing these disparities?
So there are, so we know, as I show in some of the slides, we know that most of our children are actually accessing care. It definitely, that rate goes down as parents actually, you know, as the rate of parental insurance coverage goes up. But we know that children are accessing care. One of the things that we know that we're not doing is recommending the vaccine at the level that we should. And in particular, we're not recommending the vaccine strongly. So one of the things that we know that clinical settings and providers in general are doing is offering the HPV vaccine as an addition, with a lot of hesitancy, and not actually wanting to open potentially a discussion about it. And the one thing that providers can do in clinical settings can do, without looking at the broader issues of healthcare insurance, health insurance, et cetera, is we should be offering the vaccine to all kids, all eligible kids that are actually attending our clinics, and providing them with a strong recommendation. With that, we should be able to increase the vaccination rate significantly. Once we're done with that, we should actually spend our work to overcome some of these more environmental, more population-based barriers, which include policies to reduce barriers to access health insurance for children. So we expand or increase income eligibility for Medicaid or State Children Health Insurance Program. For example, in New York City, we have a program specifically for children that are underinsured, and so any extra costs that they might have, even administrative fees that they might need to pay for when they go and get immunizations, will be covered under that, are covered under that program. So any of those actually definitely help. But it shouldn't actually stop at the level of the children. We should always look at the parents as well too, because I think one of the lessons here is that access to care, parental access to care, does play a significant role in children's access to care. So we should not overlook at what is happening at the parental level, and some of the areas that they have to access care for the purpose, in this case, of immunizations and HPV in particular.
We have a question in the chat from Dr. Yee. Do your findings imply that there isn't anything specific about HPV vaccination? Do other recommended vaccines such as hepatitis B have similar concerns about underutilization?
So there is definitely something specific to HPV, and I'll address that in a minute. But what we have learned throughout the evidence in the literature, throughout the public evidence that we have, publicly available evidence, and through our evidence, is that if the recommendation is made strong, and most importantly, if HPV vaccine is part of those vaccines that are mandatory for school, for example, most parents will accept the vaccine without hesitancy, without any hesitation, and children, including adolescents, will actually get the vaccine. So there is actually something specific. With that said, there's something specific to HPV vaccination, and it started in 2006 when it was first approved. This vaccine was politicized from the beginning. It is a vaccine against a sexually transmitted infection that in the long term can cause an infection in the long term can cause cancer. And that became a political issue since day one and continues to be. HPV, and those of us that have been working on HPV vaccine for many years, were what we call the original vaccine hesitancy professionals or researchers. COVID came afterwards, and vaccine hesitancy for COVID came afterwards, and it's just part of the same trend of politicizing and misrepresenting data from vaccine as part of the anti-vaccine efforts of many. But again, I don't want to miss the opportunity to say that HPV vaccination does have an issue. One is that, again, it's a sexually transmitted infection. It has been politicized tremendously. There's a misconception that it's only for girls, that HPV only affects girls. The vaccination recommendations by providers are most of the time stronger for girls than for boys. And that does not happen with, for example, hepatitis B, which is also a sexually, or could be also a sexually transmitted infection. Again, that plus the difference that hepatitis B is given during the first year of life, and there are no questions asked, as opposed to a vaccine that is given at starting age 9, with all the potential myth and misinformation can come as children become sexually active, and this is actually a vaccine for sexually transmitted infection. But with that long response, I do want to actually emphasize that we know that a prime parent with the needed knowledge and with all their questions answered, and in a setting where the provider, regardless if it's a nurse, a physician assistant, an immunization champion, or a physician, in a setting that provides a strong recommendation for the vaccine, almost always actually adheres to that recommendation and gets the vaccine.
Thank you. We have another question here. We're very familiar with vaccine hesitancy in Minnesota for many reasons. How much resistance do you find comes from religious organizations, particularly with concerns around perceptions of promoting promiscuity? And how do you overcome that if it is a significant source of hesitance?
It is. So we have a whole set of qualitative data that was obtained through this large study in these 4 different cities. And again, we're starting to look at that data. We don't have a large analysis. We haven't completed the analysis at all. We know that some religiosity does play a role with HPV vaccine, or at least the increase in the number of myths and misconceptions about HPV vaccine. But it's not a main barrier for the Latino population. That might be different for other populations, but it's not a main barrier. With that said, at the beginning, when the HPV vaccine was first approved and then became available for girls, and then a few years later for boys, religion barriers were actually prominent. This is a sexually transmitted infection, and they use that and the use of potential promiscuity as a reason not to actually vaccinate. I want to note actually here that there has been large studies looking at promiscuity post-vaccination, and there's absolutely no difference between the population that has been vaccinated versus those that have been vaccinated. Quite the opposite. So it was a barrier. It is definitely something that needs to be considered, but it's definitely not as strong in this population as it is for others. Now, it should be part of the conversation. And one of the things that we do is we actually give talks to the population at churches for this particular talk. And I don't modify it too much. I think having an honest conversation everywhere, regardless of who the audience is actually important. More often than not, I see that I receive my information is received well. There are multiple questions, and many parents, even those that actually are attending church, for example, where we're providing this talk, do actually agree, are interested to get the vaccine, and do end up getting them. So it's an issue, but I wouldn't actually put it at the top. That might change, actually, I'm sorry, that might change as things go. There has been a tremendous amount of changes in vaccine hesitancy in the past 2 years, for worse. And I do believe from anecdotal data that HPV actually, again, hit hard by this misinformation and anti-vaccine sentiment that is actually permeating to most populations now. It used to be that anti-vax information was, within the highly educated, highly socioeconomic status populations in large cities, etc. That is actually not the case now. It's permeating to most populations. As I mentioned in one of my slides, we're conducting a study on in our catchment area here, looking at that, and we have noticed that misconceptions, anti-vaccine information has permeated to all populations in the regardless of their ethnicity, race, etc.
Okay, a couple of further questions. Next is from Serena Zhang. Great presentation. My question pertains to the decision-making process between parent, guardian, and child. What does this process look like for Latino families, for example, authoritative, shared, etc.? And how much of a role does the child play in making or informing decisions to initiate the HPV vaccine series? And I'm going to tack on a sub-question to that, is what does that start to look like when we're talking about catch-up groups? And this balance between authoritative, strong recommendation models versus the more shared decision-making models. If you could kind of reflect on that, both for Latino families and HPV vaccination beyond childhood.
Mm-hmm. So a couple of ways to answer the question, the multiple areas of the question. One is that traditionally Latino populations have been have accepted highly the recommendations from their providers. So they take the word from the provider, and most of the time act on that. And that is particularly true for immunizations. We do see, for example, in these 4 cities where this study was conducted, this last study was conducted, that Latinos have some of the highest rates of immunizations for all. Traditionally in Latin America, immunizations have been seen as something that is not controversial. In some countries, even the government, the central government goes to your home to vaccinate your children or your child. And it has been seen as again, as non-controversial. So when it comes to vaccinations, Latino population, and this is a generalization, Latino population have very little hesitancy to obtain them. Now, how much of the decision is in the parent versus in some cases the adolescent? Well, the vaccine is actually recommended, although I disagree with it. With this is mostly recommended at age 11 and 12 when the child is actually seeking other immunizations. So the idea is that you will piggyback HPV into those other 2 vaccinations they're looking for at age 11 and 12, and they will get the vaccine at that moment. It hasn't worked that well. It's actually a strategy, but it hasn't worked that well. At that age, you still get the parent as the driving force behind the decision of getting vaccinated or not. I would say from what we see, all the way up to 14 years of age, we have seen the parent as being the significant decision maker in the Latino population when it comes to getting the vaccine. After that is the discussion with the adolescent. There's no reason to provide the vaccine at age 9, 10, or 11, but 9 or 10, but that's a different discussion. When it comes to adolescents, I have no experience in that communication, but we do direct experience. So we do know that the communication with Latino adolescents, most of the time when there's actually a provider that is actually Latino, speaks Spanish, if the adolescent speaks Spanish, etc. Most of the time, the result of that communication or that offering of the vaccine is actually positive, and they end up actually getting the vaccine. That's a little bit of the information that I have, but it's a long question and a long answer, and could be a longer because it embodies a lot of different aspects of the access to care for Latino populations, etc.
And just finally, we have a comment from Cynthia Pando about the value of school mandatory requirements. So I think we're probably all on the same page there, but we're at the hour, and I just want to thank you again for a fascinating presentation and a stimulating discussion, and thank you all that attended today. And we look forward to seeing you at the next seminar. Thanks again.
Thank you so much for the invitation. Thank you, everyone.